I address you on World AIDS Day 2022 in honor of those whom you and I have both lost, but also with high hopes for a future we must collectively realize, one in which new HIV infections are exceedingly rare, AIDS-related deaths are a thing of the past, and people living with and affected by HIV are not subjected to inequality and marginalization. As I contemplated my remarks for this year's World AIDS Day, I hearkened back to the expiration of the Millennium Development Goals in 2015, which gave way to the Sustainable Development Goals, which UN member states committed to achieve by 2030. While HIV was downgraded slightly in the SDGs from being a part of a primary goal, it was included as a target under a broader goal to ensure healthy lives and promote well-being for all at all ages. Moreover, the SDGs added the audacious goal to end AIDS as a public health threat by 2030. While there neither was then, nor is now, a cure for and/or vaccine against HIV, this type of aspirational thinking became possible because of therapeutic and preventative innovations that have continued to make antiretroviral drugs more effective, as well as expand the HIV prevention armamentarium, leading for IAPAC's push to promote HIV epidemic control in every country of the world. In 2012, the first year we convened our Controlling the HIV Epidemic Summit, the U.S. Food and Drug Administration had just approved a once-daily pill to reduce HIV acquisition by up to 98% among those who are potentially exposed, an antiretroviral regimen we know as pre-exposure prophylaxis, or PrEP. The World Health Organization issued normative guidance regarding PrEP scale-up that same year, and global availability has grown since then, albeit at glacial pace and regrettably in an inequitable manner. Furthermore, several studies, including HPTN-052, prove the concept of HIV treatment as prevention, or TASP, meaning that individuals living with HIV on antiretroviral therapy, or ART, who reach a sustainably undetectable viral load, no longer transmit the virus to their sexual partners. From this understanding emerged the HIV community-based undetectable equals untransmissible, or U equals U, a message that frames TASP in a user-friendly catchphrase and serves the dual purpose of destigmatizing an HIV diagnosis by boldly addressing the long-standing fear and ensuing stigma against people living with HIV. Thus, our global targets with respect to controlling the HIV epidemic began to reflect the evidence-based reality that doing so is finally within our reach. The 2016 UN Political Declaration on HIV established that by 2020, we would have reduced new HIV infections by 75% compared to 2010 numbers, and would also attain what became known as the 90-90-90 targets. Only 2 countries documented success at reaching a 75% reduction in new HIV infections, and only a handful were documented as having met the 90-90-90 targets. The progress made between 2015 and 2020 was classified by UNAIDS as important but insufficient. Nevertheless, the 2021 UN Political Declaration on HIV pressed ahead with the increasingly ambitious goal of ending AIDS as a public health threat by 2030, and set a bar higher than the initial 90-90-90 targets, which with each 90 target now replaced with a 95% target to be attained by 2025. Additional targets are to be achieved within the same time frame, including that at least 95% of people at risk for HIV infection should have access to combination prevention, that no more than 10% of people living with HIV should experience stigma or discrimination, and that community-led organizations should deliver 30% of HIV testing and treatment services, 80% of HIV prevention services, and 60% of programs aimed at leveraging social enablers to enhance the effectiveness of HIV programs. The need for these additional targets reflects deep and persistent inequalities that exacerbate the HIV pandemic and the powerful social and political determinants of health that have shaped its trajectory over the past 4 decades. Even in countries that attained or came close to attaining the 90-90-90 targets, the results have been inequitable. For example, while some countries met or surpassed one or more of the 90% targets, certain communities of people remain disparately affected by HIV. The reality is that even in countries, municipalities, and cities that have made the most progress towards ending their HIV epidemics, the same inequalities that have defined jurisdictional HIV epidemics and the HIV pandemic for decades, and some since the mid-1980s, remain stubbornly persistent. The trends on a regional level are also unequal, with sub-Saharan Africa representing only 1/7 of the world's population and yet 2/3 of the global population of people living with HIV. These inequalities and resulting inequities can largely be understood by examining social determinants of health, which the WHO defines as the conditions in which people are born, grow up, live, work, and age. Given the vast inequities and inequalities between and within nations with respect to social determinants such as housing, employment, healthcare access, and more, it is not hard to understand how the fight for equality in reference to HIV is an uphill battle so long as gender, racial, socioeconomic, and other inequalities remain so stark. Closely connected to social determinants of health are political determinants, which have been defined as the norms, policies, and practices that arise from global political interaction across all sectors that affect health. While resource limitations make social determinants of health difficult to address, the political dimensions are largely to blame for lack of progress in addressing socioeconomic and other inequalities. Some of this lack of progress in reducing inequalities has to do with the continued political domination by a small group of powerful interests who have every intent to maintain the status quo of haves and have-nots. HIV responses have also been hindered from the very start by other political calculations, including most prominently stigmatizing attitudes towards vulnerable populations that are most greatly affected by HIV, as well as a rejection of harm reduction methods based on moral philosophy versus scientific evidence. Meanwhile, political resistance towards expanding healthcare access and improving health systems, as well as to strengthening global public health, have made for a weak foundation from which to build and sustain HIV responses. Global HIV financing specifically has also been on the decline since its peak in 2012, a year during which, at the first Controlling the HIV Epidemic Summit, we warned of worrying signs that yearly spending might fall short of what was needed to control national HIV epidemics, a warning that sadly became reality as UNAIDS estimates a 31% gap in the global HIV budget. With no cure or vaccine yet on the immediate horizon for HIV, these budget shortfalls and political shortcomings mean that we will not be able to fully implement HIV prevention measures or HIV test and treat for all in need, increasing the number of people affected by HIV and therefore the long-term costs in lives and coin of achieving our goal. Moreover, so many of our wounds in the collective fight to end HIV have been self-inflicted by governments that, even as they claim to desire the HIV pandemic's end, target those most affected with stigmatizing and discriminatory laws and attempt to reduce rather than expand healthcare access for all. That is largely why the lags in our global, national, and municipal HIV responses reflect underlying social inequalities with disproportionate impact among key populations, including transgender individuals whose identities are violently suppressed, people who inject drugs who are treated as criminals rather than fellow community members in need of recognition and support, racial and ethnic minorities who lack access to socioeconomic opportunities and must too often confront racism, and women and girls who far too often lack a voice about their own bodies and healthcare decisions. Ending the HIV pandemic does not just mean suppressing or even curing the virus, but rather addressing the myriad injustices that are in both causes and effects. At the end of the day, HIV has always been as much an issue of human rights and social justice as it has been about public health or science. As the saying goes, a high tide lifts all boats, and by addressing HIV in a rights-based and holistic manner, we will see dividends paid in all areas of human development. As we commemorate World AIDS Day 2022, I ask each of you to recommit to the fight we have been waging against this insidious virus, a virus that has claimed more than 40 million lives, in whose honor we must carry on. but equally insidious are the persistent and dangerous inequalities about which the UNAIDS report released this World AIDS Day speaks about so eloquently. Increases in new HIV infections of 1.5 million per year and AIDS-related deaths of 650,000 per year are the result of multiple factors, including pernicious stigma and discrimination, but also gender inequalities, inequalities faced by key populations, and inequalities between children and adults. We understand the task ahead of us. Thus, those of us who form the HIV community must, in our hearts and minds, determine whether our individual and collective actions will make a meaningful contribution towards realizing, in the words of the Universal Declaration on Human Rights, our collective recognition of the inherent dignity and of the equal and inalienable rights of all members of the human family. And so I say on World AIDS Day 2022, let us make health and well-being the great equalizers, turning on its head the convention that death is the great equalizer. Let's honor the millions lost to AIDS, but also the millions living with and affected by HIV by committing ourselves to health and social equality.